Welcome to this comprehensive masterclass. Today we are architecting health sovereignty by deconstructing the invisible injury of concussion and mTBI. As I always say, pain is not a diagnosis, it is a signal. And in the case of mTBI, it is a signal of a systemic neurological crisis that we must quantify. The trap begins in the emergency room. You feel foggy, your head is pounding, yet you are told your CT scan is normal, but you are not fine. Concussions are not just medical events. They are life-altering socioeconomic catastrophes affecting millions of sovereign seekers globally. We must distinguish between structural damage and functional impairment. CT and MRI find fractures and bleeds, but they miss the microscopic cellular distress. Literature confirms that mild traumatic brain injury is primarily a microscopic event, axonal shearing and metabolic mismatch that standard neuroimaging cannot detect. Insurance companies exploit this gap. They use algorithms like Colossus to argue that if it's not on an X-ray, it's not real. We are here to prove them wrong. Advanced techniques like diffusion tensor imaging, or DTI, allow us to visualize the integrity of the white matter tracks, the brain's data cables. By measuring fractional anisotropy, we can objectively quantify the disruption of water molecule movement within these tracks, identifying injury where MRI is silent. Recent data shows that 30% of patients with a normal CT scan show brain lesions when more sensitive MRI or DTI sequences are performed. We have entered the era of the biochemical fingerprint. Since 2018, blood biomarkers have revolutionized our ability to detect cellular distress. We track GFAP, a marker for astrocytic glial injury, and UCHL1, the marker for neuronal cell body damage. Both are critical for objective proof. Timing determines diagnostic utility. Scientific data from the ALERT and TRACK-TBI trials have established clear temporal profiles for these proteins. UCHL1 is our hyperacute signal. It rises rapidly, peaking at 8 hours post-injury, but clears within 48 hours. If you wait, you miss the window. GFAP is the sustained marker. It peaks at 24 hours and remains detectable for up to 7 days, providing a reliable window for those who seek care later. At the Padda Institute, we utilize point-of-care tools like the iStat Alinity to get these biochemical results in 15 minutes, guiding immediate clinical decisions. The combination of GFAP and UCHL1 achieves a negative predictive value of 99.6%. This is objective data that insurance companies simply cannot ignore. Crucially, these day of injury levels predict functional recovery outcomes at 6 months. High levels indicate a greater risk of incomplete recovery. In pediatric populations, we must be even more diligent. GFAP is highly sensitive in children, providing a safe alternative to radiation-heavy CT scans. While GFAP levels vary by age in children, UCHL1 remains a stable marker, allowing us to quantify neuronal distress even in our youngest sovereign seekers. Neurofilament light, or NFL, is the marker for chronic axonal damage. Unlike acute markers, NFL persists for months, revealing ongoing neurodegeneration. IS-100B is another critical rule-out tool with 98% sensitivity, used extensively in our protocols to avoid unnecessary radiation while ensuring safety. TBI is a chronic inflammatory process. Alarmins like HMGB1 trigger secondary injury cascades that can last for months or years if not addressed. Persistent neuroinflammation is driven by chronic activation of microglia and astrocytes, the brain's immune system gone haywire. We must reset this terrain. We analyze the complex cytokine matrix, markers like TNF-alpha and interleukin-10, to map the biological soil of your inflammation. Our data-driven approach measures your biological soil through markers like LDLP, TNF-alpha, and high-sensitivity CRP to ensure system regeneration. The UCLA RAPI study identified a TBI slow subset, showing progressive structural damage and slower information transfer across the corpus callosum. These patients exhibit higher restricted diffusion imaging metrics, sensitive to the ongoing inflammatory processes that cause secondary brain injury. To bridge the gap between subjective symptoms and objective evidence, we deploy rigorous neurocognitive testing. This isn't just opinion, it's data. The Standardized Assessment of Concussion, or SASC, provides immediate data on orientation and immediate memory, revealing functional deficits. The SCAT-5 is our comprehensive tool, analyzing balance, coordination, and symptom burden through an objective scientific lens. Impact testing is our sophisticated computerized tool that measures processing speed and reaction time with sub-millisecond accuracy. Significant deviations from normative data provide the objective measures of impairment needed to substantiate a legal claim and guide recovery. The JAMA 2025 study validated sensorimotor peak alpha frequency and corticomotor excitability as objective cortical biomarkers for pain sensitivity. By analyzing EEG and TMS data, We can predict who will transition from acute to chronic pain, allowing for proactive intervention with the PADA protocol. We are moving toward multi-omics, analyzing lipids and microRNAs to create a simple blood test that definitively confirms brain trauma. The myth that you must lose consciousness to have a concussion is scientifically false. Symptoms like nausea and ringing ears can emerge days later. These delayed symptoms, foggy thinking, pounding headaches, are often the most critical signals of an underlying mTBI that require immediate care. This is why having a well-trained physician, board certified in anesthesia or neurology, is critical for your recovery and your claim. We use specialized tools, including clinical findings from physical exams and diagnostic nerve blocks, to reveal hidden pain generators when the MRI is silent. We pinpoint exactly where the signal is coming from. We don't just treat the pain, we identify the source and architect your regeneration. Our PADA protocol utilizes peptide therapy, organized into 5 categories like the Wolverine stack and metabolic masters, to restore your system. As of February 2026, 14 vital peptides have been returned to Category 1 status, providing us with powerful tools for your recovery and performance. We must talk about the numbers. Concussions are not just medical bills, they are life-altering financial catastrophes that we must quantify. Literature is clear. A TBI is associated with a 17.9% average personal income loss in the first year following an injury. This is a scientific fact. Lifetime treatment costs for a traumatic brain injury can range from $85,000 to over $3 million. Your claim requires a rigorous financial analysis. It's not just about what you spent at the hospital. It's about the wealth you can no longer generate because your injury prevents working at full capacity. You deserve more than a normal scan. You deserve the PADA protocol. We are your gateway to regeneration, located right here at the Lambert Airport. Don't let an insurance adjuster or a normal scan discourage you. We have the tools to identify the signal and architect your recovery. Invisible injuries are real, and the science to prove them exists. Seek care with us at the Concussion Center and Injury Experts. Let's find the signal together.